Hi, my name is Chelsea McManus.
And I'm Haley Collins, and this is our presentation on childhood onset schizophrenia.
Childhood schizophrenia is an uncommon but severe mental disorder in which children interpret reality abnormally. Childhood schizophrenia, defined by an onset of psychosis by age 12, is clinically and neurobiologically continuous with the adult onset disorder. Schizophrenia involves a range of problems with cognitive abilities, behavior, or emotions. It may result in some combination of hallucinations, delusions, and extremely disordered thinking and behavior that impairs a child's ability to function.
Most children with schizophrenia show delays in language and other functions long before their psychotic symptoms appear. In the first years of life, about 30% of these children have transient symptoms of pervasive developmental disorder, such as rocking, posturing, and arm flapping. Childhood onset of psychosis may present with poor motor development, such as unusual crawling, and children may be more anxious and disruptive compared to those with later onset. There are also many warning signs, such as the ones we've listed on our slide.
There are positive and negative symptoms associated with this disorder. Positive symptoms, which are disturbances that are added to the person's personality, consist of delusions, for example, when an individual believes that someone's spying on him or her, hallucinations, seeing, feeling, tasting, hearing, or smelling something that doesn't really exist, disordered thinking and speech, moving from one topic to another in a nonsensical fashion. Individuals may also make up their own words or sounds, rhyme in a way that doesn't make sense, or repeat words and ideas. Disorganized behavior. This can range from having problems with routine behaviors like hygiene or choosing appropriate clothing for the weather, to unprovoked outbursts to impulsive actions. Then there are negative symptoms, which are capabilities that are lost from the person's personality. These consist of social withdrawal, extreme apathy or a lack of interest or enthusiasm, lack of drive or initiative, and emotional flatness.
In a case study we found, 81 out of 82 of the children with schizophrenia had at least one comorbid psychiatric illness. ADHD came in at 84%, oppositional defiant disorder 43%, depression 30%, and separation anxiety disorder was at 25%. These were the most common comorbid conditions identified. Early diagnosis and medical treatment are very important. It is especially important that children and youth with the problems and symptoms we've already listed receive a complete evaluation. These children may need individual treatment plans involving other professionals. A combination of medicine and individual therapy, family therapy, and specialized programs, such as early psychosis treatment, is often necessary. Changes in lifestyle, additional supports, such as therapy and school support, and psychiatric medication can be helpful for many of the symptoms and problems identified.
Cognitive behavioral therapy, often referred to as CBT, is an example of evidence-based treatment. CBT aims to generate links between patterns of thoughts, feelings, and behaviors using cognitive restructuring to facilitate the understanding and management of these behaviors. It can be targeted at positive and negative symptoms, as well as other associated experiences such as depression, reducing psychotic relapse, and improving coping. Patients are encouraged to challenge the underlying thought patterns which cause distress and to use reasoning and personal experience to generate rational, alternative explanations for these thoughts. A variety of interventions can be labeled as CBT, but the primary goals focus on coping strategies and problem-solving skills. Overall, quality evidence suggests a significant effect of CBT for improving symptoms, particularly positive symptoms, when compared to treatment as usual. CBT may improve functioning, mood, hopelessness, and insight into the illness. It may also reduce mortality, increase discharge rates from hospitals, and improve attitude toward medications. Group CBT may reduce hospital readmission rates, social anxiety, and depression.
Short-term studies have indicated a greater favoring of clozapine over other agents in alleviating negative symptoms in childhood-onset schizophrenia patients. In another study we found, the authors presented the results for long-term medication maintenance over a 24-year observation period for their group of 131 patients with COS. Of this cohort, 91% were available for follow-up information from either in-person or telephone contact with the patient and/or family members. Short-term data on effectiveness and long-term maintenance suggest a possibly greater value of clozapine relative to other antipsychotics for children with schizophrenia. The overall findings indicate that very early onset schizophrenic patients may be more responsive to clozapine. This supports many others' research on clozapine as an option in the treatment of early onset schizophrenia. During the past 2 decades, the Child Psychiatry Branch at the National Institute of Mental Health has conducted a longitudinal study of childhood onset schizophrenia. COS, characterized by onset before age 13 years, has a prevalence of approximately 1 in 40,000.
Although it's unclear whether schizophrenia has single or multiple underlying causes, evidence suggests that it is a neurodevelopmental disease likely involving a genetic predisposition, a prenatal insult to the developing brain, and stressful life events. Prenatal insults may include viral infections such as maternal influenza in the second trimester, starvation, lack of oxygen at birth, and untreated blood type incompatibility. The role of genetics has long been established. The risk of schizophrenia rises from 1% with no family history of the illness, to 10% if a first-degree relative has it, and to 50% if an identical twin has it. Studies find that children share with adults many of the same abnormal brain structural, physiological, and neuropsychological features associated with schizophrenia. The children seem to have more severe cases than adults, with more pronounced neurological abnormalities. This makes childhood onset schizophrenia potentially one of the clearest windows available for research into a still obscure illness process.
Many of the symptoms seen in people with schizophrenia are also found in people with depression, bipolar disorder, or other illnesses. As a result, studies have found that misdiagnosis is common. This is particularly true with children and adolescents. As such, it is extremely important to rule out other diagnoses such as depression, bipolar, and substance use before making a diagnosis of schizophrenia. Examining the mental state of a child can be difficult, but this becomes further complicated in the presence of a developmental delay. COS is sometimes misdiagnosed in cases of autism spectrum disorder due to the similarities in symptom presentation. The symptoms of ASD, such as disorganized speech and flat affect, can mimic the negative symptoms observed in childhood onset schizophrenia. The social deficits seen in ASD may also be confused with the social impairment and atypical beliefs that children with schizophrenia often display.
We would like to conclude by stating that schizophrenia is a chronic condition that requires lifelong treatment.
But identifying and starting treatment for childhood schizophrenia as early as possible may significantly improve a child's long-term outcome.
We would like to thank all of you for watching our presentation. If you have any questions, please feel free to ask.
Thanks!